Yeah, hope everyone is doing good. We can start, Allah.
Anna.
Yeah, hope everyone is doing good. So, yeah, in the previous class of bile duct, we had discussed about two basic bile duct pathologies, that is choledochal cyst and choledocholithiasis, that is abnormal dilatation of the bile duct and a stone in the common bile duct or a stone anywhere in the bile duct. So after that, we are now starting with the third pathology of bile duct, that is cholangitis. So what does this cholangitis mean basically? Cholangitis, itis stands for inflammation. So anywhere itis stands for inflammation. Okay, itis means inflammation. Cholange refers to bile duct. So inflammation of bile duct anywhere is called as cholangitis. So if there has to be inflammation of the bile duct, there is two mandatory principles. One, there should be obstruction anywhere in the bile duct, or there should be infection. So what are the predisposing factors which lead to inflammation in the bile duct? So predisposing factors include choledocholithiasis, which is the most common. That is the most common mode of obstruction. If there is a stone, that is, if there is a gallstone in the common bile duct, that is called as choledocholithiasis, and that is most common. This will lead to obstruction, which will serve as a source of infection and hence leading to inflammation. Okay, now other than that, biliary stricture. What does the biliary stricture mean? Normally bile duct will be like this. If there is a stricture, there will be narrowing of the bile duct. So because of this narrowing, there will be accumulation of bile, and because of this will serve as a source of infection, and because of that cholangitis happen. So biliary stricture. Choledochal cyst, we had discussed about the choledochal cyst, that is abnormal dilatation of bile duct. So because of this, there will be accumulation of bile which will serve as a source of infection and hence leading to cholangitis. Again, cholangiocarcinoma, same, there will be a mass growing from the bile duct. So ಇಲ್ಲಿಂದ ಒಂದು ಮಾಸ್ ಈ ಥರ ಬೆಳೆಯೋಕ್ಕೆ ಶುರುವಾಗುತ್ತೆ. This will lead to obstruction, and basically that will lead to cholangitis. Other than that, worms. This is the mechanism which we had discussed in brown pigment stones. There will be ascaris or round dead worms which will get accumulated in most commonly in the common bile duct, because of which there will be formation of an enzyme called as beta glucuronidase, which will cause breakdown of biliverdin to bilirubin, which is brown in color, and hence the brown pigment stones. So basically these are all the predisposing factors which will lead to obstruction or infection and thereby causing cholangitis. So either pathophysiology. What is the most common organism? That is E. coli, because E. coli is the most common gut bacteria. It is usually present normally. So if it is present in gut, it will not be causing any harm. If it reaches somewhere else other than gut, there will be imbalance and hence it will cause pathology. Okay, so E. coli is the most common organism. Other than that, it is Klebsiella. So infection, whichever is there in this common bile duct or whichever is there in the bile duct, it will reach the systemic circulation by two ways: cholangio, that is bile duct, to venous reflex. So what is this cholangio venous reflex? So now the infection is here. Just like I have explained before also, bile duct is also having its own blood supply. So whenever there is infection in this bile duct, it will reach systemic circulation through hepatic veins. So because of this, it will reach blood in the venous system. And where does the blood go? It goes everywhere throughout the body. Hence whatever the infection is there here, this will reach the venous system and thereby reaching entire body, thereby causing systemic manifestations. ಇವಾಗ ಬಾಡಿಯಲ್ಲಿ ಎಲ್ಲೋ ಒಂದು ಕಡೆ ಇನ್ಫೆಕ್ಷನ್ ಇದ್ದರೆ ಎಂಟೈರ್ ಬಾಡಿಗೆ ಯಾಕೆ ಫೀವರ್ ಬರುತ್ತೆ? ಬೇಸಿಕಲಿ ಬಿಕಾಸ್ ಆಫ್ ದಿಸ್ ಬ್ಲಡ್ ಸಿಸ್ಟಮ್. ಓಕೆ, ಬ್ಲಡ್ ಗೋಸ್ ಎವ್ರಿವೇರ್ and thus it leads to systemic manifestations. Similarly, the bile duct also has a lymphatic supply, and because of this it can reach cholangiolymphatic reflex. So basically reflex andre ಏನು, just like I have explained before, there are valves in the bile system which will help flow of bile in unidirection. But since there is accumulation of bile, or because of this whatever infection or obstruction, there is reflux through venous system or through lymphatic system, and hence it will reach systemic circulation. Okay na? So normally the pressure in the bile duct or common bile duct is 10 to 12 centimeter of water. So when there is obstruction, there will be increased pressure inside the common bile duct, which will cause reflux, which can be cholangiovenous or cholangiolymphatic. Okay, so yeah, what will be the clinical features in case of cholangitis? Just like I said, it is inflammation. So wherever there is inflammation, there will be pain. After this, since there is obstruction to the bile flow, there will be obstructive jaundice. After this, because it is an infection, it will spread to systemic circulation, thus causing fever. So these three symptoms is called as Charcot's triad of cholangitis. Okay, na? So this is Charcot's triad of cholangitis. If there are two more symptoms, so after this we have not initiated any treatment anta ankolona. So because of this, what will happen? Because of fever and pain and obstructive jaundice, the person will go into sepsis. Sepsis andre severe inflammation or severe infection leading to compromise in his perfusion. Okay, so that will lead to also the fever, whichever is there, the sepsis. This will impair the mental status. The fever can reach brain and hence impair mental status. So if there is pain, obstructive jaundice, fever, along with that shock and mental status changes, then this 5 symptoms constitutes a pentad, which is called as Reynolds pentad. Okay, that is, if there is delayed treatment, then it can reach to pentad. Okay, na? So these are the clinical features, Charcot's triad and Reynolds pentad. These two are important. So okay, now we have identified that there is cholangitis and we have diagnosed it. Okay, based on the clinical symptoms itself. This is a clinical diagnosis. Okay, after this, what is the management? So probably there is shock. If there is shock, you have to treat it with adequate amount of fluids. So put 2 large IV cannula, start IV fluids, and since there can be an infection, because of that there is fever, and hence if there is infection, you need to treat it with antibiotics. So you give IV fluids and IV antibiotics. If there is no improvement, then there can be persistent obstruction. For obstruction, so basically we are going in a way. Okay, so first infection treat ಮಾಡಕ್ಕೆ try ಮಾಡಿದ್ವಿ. Infection treat ಮಾಡಕ್ಕೆ ಏನು ಮಾಡಿದ್ವಿ? Infection plus shock we are treating. Okay, so in order to treat shock, we have given 2 IV fluids, 2 large IV cannula and given IV fluids. And for infection, we have given antibiotics. So if these two are not the cause, then obstruction will be the cause. For obstruction, we have studied previously, like ERCP and MRCP. MRCP is just an investigation, this is just diagnostic. Whereas ERCP endoscopy ಹಾಕ್ತಿವಲ್ಲ, so this is both diagnostic and therapeutic. So hence we'll do ERCP, and if there is any stone which is obstructing the bile duct, then we'll remove that stone or we'll put a stent. Okay, so this is okay. After this, if ERCP is not available, or even after doing ERCP we are unable to remove stone, then we'll go for percutaneous transhepatic cholangiography, that is through liver, like this. We'll go for percutaneous transhepatic cholangiography, and then we'll basically the stone can be in the distal bile duct or in the proximal bile duct. If we try ERCP, we are trying for distal bile duct removal. If we are doing PTC, we are seeing proximal bile stone removal. Okay, so if this fails, we'll try this way, thinking that the gallstone can be in the proximal bile duct. Even if this fails, then we'll have to go for open biliary decompression. So what is open biliary decompression? Basically, you are opening the abdomen and putting a longitudinal incision over the bile duct. Longitudinal incision yakke? Because blood supply is to bile ducts is like this from either way. So if we put here the incision longitudinally over the bile duct, there will be less bleeding. Hence longitudinal incision over the bile duct, and then the stone is removed. And then we will have to insert a T-tube like this. So T-tube insertion is done. So T-tube basically helps in the drainage of bile, that's it. And then T-tube cholangiogram is after 7th to 10th day. Okay, then even after 7 to 10 day, we will retain T-tube if there is presence of distal filling defects. and this T tube is left like that for about 1 to 1.5 months. Okay, na? Okay. So yeah, this much is enough regarding cholangitis. Okay, so now till now we are done with bile duct part 1. Okay, autoimmune disorders ಅಲ್ಲಿ primary biliary cirrhosis ಬಗ್ಗೆ ಒಂದು ಹೇಳಬೇಕು, that I'll cover up. So till now we have discussed about anatomy of bile duct, and then after that we discussed about choledochal cyst, then choledocholithiasis, and now just now we discussed about cholangitis. Okay, so now coming to the last pathology regarding bile duct part 1, that is primary biliary cirrhosis. Okay, so what does the name suggest? It is primary biliary cirrhosis. There is fibrosis or cirrhosis of the primary bile duct. Okay, so this is an autoimmune disorder. Autoimmune disorder andre our body recognizes our own self as foreign agent and it will start acting against it. So it is an autoimmune disorder and it is most common in females. Okay, so what is the antibody here? Antimicrobial antibody is the auto antibody. So basically this is like a drug which is produced by our body to fight against our own body. So what is the pathology here? Because of this autoimmune mechanism, there will be progressive destruction of the intrahepatic bile ducts. So whatever the bile duct is there within the liver, this will be damaged, because our own body is thinking that these are foreign agents, and because of that there will be destruction of this intrahepatic bile duct. If there is destruction, what will happen? There will be progressive destruction. So progressive jaundice will be there ashte. So because of that there will be pruritus first and then jaundice. Okay na, progressive agi jaundice will appear only after certain destruction has occurred. So pruritus, I mean itching, will be there first. Okay na, itching and then jaundice will be there. This is a clinical feature in case of primary biliary cirrhosis. So after this there will be fatigue. That is, these are the characteristic symptoms. Most common is pruritus and this is the most bothersome in evening. Okay na, so as the like immune system will start acting more in the evening, aita, so because of that there will be more pruritus in the evening and hence there will be more itching. Okay, what are the associated? I mean, it is associated with hyperlipidemia, xanthoma or xanthalasma, and melanosis. These are all other symptoms we can say. Since it is an autoimmune condition, entire body will be affected. One part ಗೆ ಸ್ಟಿಪ್ಯುಲೇಟ್ ಆಗಿ ಇರಲ್ಲ. This will be affecting multiple organs. Hyperlipidemia is basically cholesterol. Okay, xanthoma or xanthalasma is basically like accumulation of lipids below the eyelids, like yellowish discoloration or yellowish skin hyperpigmentation we can say, that is occurring just below the eyelids. Okay na, melanosis is hyperpigmentation again. So how do we diagnose this? Basically we will confirm the antimicrobial antibody. If it is present then it is confirmed. Okay, but investigation of choice is biopsy from the intrahepatic bile duct or intrahepatic bile duct. Okay, yeah, so what is the treatment? Since it is an autoimmune disease, we can't do anything. We can just give immunomodulator drugs or we can go for liver transplantation. Okay na, so this completes part 1. So yeah, in the part 1 we have discussed the following, these 5 pathologies. Okay, yeah, now we are going for bile duct part 2. So in part 2 there are many things, but according to your syllabus I am restricting the diseases. So in the bile duct part 2 we'll just study primary sclerosing cholangitis and cholangiocarcinoma. Okay, so 2 basic pathologies we are discussing today. So yeah, first one is primary sclerosing cholangitis. So just start breaking the words. cholangitis we have already studied, that is inflammation of bile duct. ಕರೆಕ್ಟಾ? ಸೊ ಕೊಲಾಂಜೈಟಿಸ್ ಆಗ್ತಿದೆ, ಅದ್ರ ಜೊತೆಗೆ ಏನಾಗ್ತಿದೆ, ಸ್ಕ್ಲಿರೋಸಿಸ್ ಅಂದರೆ ಬೇಸಿಕಲಿ something is accumulating or something is getting filled in, and it is sclerosis. Okay, so primary sclerosing cholangitis. So this means that there is inflammation and there is basically closure or stricture of bile duct. That is what the pathology is all about. So primary sclerosing cholangitis is more common in males, and what is there? It is characterized by multiple strictures in both intrahepatic and extrahepatic bile ducts. ಸೊ ಬೇಸಿಕಲಿ ಇನ್ಫ್ಲಮೇಷನ್ ಆಗಿ ಅಷ್ಟಕ್ಕೆ ನಿಲ್ತಾ ಇಲ್ಲ, ಇಲ್ಲೇನಾಗ್ತಾ ಇದೆ, ಸ್ಕ್ಲಿರೋಸಿಸ್ ಆಗಿ ಸ್ಟ್ರಿಕ್ಚರ್ಸ್ ಫಾರ್ಮೇಷನ್ ಆಗ್ತಾ ಇದೆ. ಸೊ ಇವಾಗ ಒಂದಷ್ಟು ಇಂಟ್ರಾಹೆಪಾಟಿಕ್ ಬೈಲ್ ಡಕ್ಟ್ಸ್ ಇದೆ. ಓಕೆ, ಸೊ ಇದು ರೈಟ್ ಹೆಪಾಟಿಕ್ ಡಕ್ಟ್, ಲೆಫ್ಟ್ ಹೆಪಾಟಿಕ್ ಡಕ್ಟ್ ಫಾರ್ಮೇಷನ್ ಮಾಡುತ್ತೆ. ಆಫ್ಟರ್ ದಿಸ್ there will be gallbladder, cystic duct, and this will continue along with pancreatic duct. It will open in ample of water. Okay, ಇಷ್ಟು ಗೊತ್ತಿದೆ ನಮಗೆ, ಆಯಿತಾ? ಸೊ ಹಿಯರ್ ವಾಟ್ ಇಸ್ ಹ್ಯಾಪನಿಂಗ್ ಇಸ್, ಇಟ್ ಈಸ್ ಆಲ್ಸೋ ಲೈಕ್ ಬೇಸಿಕಲಿ ಲೈಕ್ ಆಟೋಇಮ್ಯೂನ್ ಅಂತ ಅನ್ಕೋಣ. ದಿಸ್ ಈಸ್ ಲೀಡಿಂಗ್ ಟು ಇನ್ಫ್ಲಮೇಷನ್. ಫಸ್ಟ್ ಕೊಲಾಂಜೈಟಿಸ್ ಆಗ್ತಿದೆ in both intrahepatic and extrahepatic bile duct. After this, what is happening? There is deposition of some substance which is leading to stricture, basically narrowing of the bile duct. So narrowing aitandre there will be cholestasis, slowed movement of bile, because of which there will be increased infection, and that will lead to all other pathology. So this is also a autoimmune disease, hence the name primary sclerosing. Primary is basically saying that there is no particular cause. ಆಯಿತಾ? ಪ್ರೈಮರಿ ಅಂದರೆ ಬೇಸಿಕಲಿ there is no particular cause, it is due to autoimmune mechanism. Secondary ಅಂದರೆ there will be a particular cause. Okay, so primary sclerosing is autoimmune, hence it is associated with HLA-B8 and HLA-DR3, which is associated with ulcerative colitis also. Ulcerative colitis ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ, just like the name suggests, colon has ulcers, ulcerative colitis. So this is associated with ulcerative colitis. ಆಯಿತು. ಸೊ ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸ್ ಇವಾಗ ವಾಟ್ ಈಸ್ ದ ಅಸೋಸಿಯೇಷನ್ ಅಂತ ಕೇಳಿದರೆ ಎಷ್ಟು ಪರ್ಸೆಂಟ್ ಇದೆ ಅಂದರೆ, ಇವಾಗ ಯಾರಲ್ಲಿ ಪ್ರೈಮರಿ ಸ್ಕ್ಲಿರೋಸಿಂಗ್ ಕೊಲಾಂಜೈಟಿಸ್ ಇರುತ್ತೆ, ಐ ಮೀನ್ ಹೂ ಹ್ಯಾವ್ ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸ್, ಇನ್ ದೆಮ್ 5 to 6% cases will have primary sclerosing cholangitis, whereas it's ulta. If they have primary sclerosing cholangitis, then 70 to 80% cases will have ulcerative colitis. Okay na? So one thing to remember for MCQs is smoking is protective in certain conditions, certain autoimmune disorders like ulcerative colitis, primary sclerosing cholangitis, Parkinson's disease and Alzheimer's disease. Okay, so yeah, what is the pathophysiology in primary sclerosing cholangitis? Basically, target cell of injury in primary sclerosing cholangitis is cholangiocytes, which are the cells lining the bile duct. So basically, if there is a bile duct, it will have cells lining the bile duct, and these are called as cholangiocytes. So ಈ primary sclerosing cholangitis ಅಲ್ಲಿ these cells are target cells, ಅಂದರೆ these cells will be destroyed. ಆಯಿತಾ? ಸೊ ಏನಾಗುತ್ತೆ, ಸ್ಟ್ರಕ್ಚರ್ ಫಾರ್ಮೇಷನ್ ಇನ್ ಬೋತ್ ಇಂಟ್ರಾಹೆಪಾಟಿಕ್ ಆ್ಯಂಡ್ ಎಕ್ಸ್ಟ್ರಾಹೆಪಾಟಿಕ್ ಬೈಲ್ ಡಕ್ಟ್ ವಿಲ್ ಹ್ಯಾಪನ್ ಬಿಕಾಸ್ ಆಫ್ ದೀಸ್ ಡ್ಯಾಮೇಜ್ ಟು ದೀಸ್ ಸ್ಟ್ರಕ್ಚರ್ಸ್. ಓಕೆನಾ? intrahepatic and extrahepatic. So because of this there will be narrowing of the bile duct. This is nothing but stricture. So after this gives onion skin appearance or with cut section. Okay, so ಈ ಥರ ಕಾಣಿಸುತ್ತೆ ಅಂತ ಹೇಳ್ತಿದ್ದಾರೆ. Okay, so destruction of terminal intrahepatic branches will also happen, and this gives pruned tree appearance, because of selective destruction of terminal intrahepatic branches. ಇಷ್ಟೆಲ್ಲ ಬೇಕಲ್ಲ, these are basically for identification in the pathology. ಆಯಿತಾ? So there is a patient with multiple strictures and on cut section it gives onion peel appearance. What is the diagnosis? ಈ ಥರ ಕೇಳ್ತಾರೆ ನಮಗೆ MCQs. So only for those reason for integration of surgery and pathology we'll need all this, and hence they have given all this. Aita? So what we need to understand is, in case of primary sclerosing cholangitis, it is an autoimmune condition in which cholangiocytes, that is the cells lining the bile duct, will be targeted, and this will lead to multiple strictures which can be in the intrahepatic as well as in the extrahepatic bile ducts, because of which there will be following clinical features. Enagutte, there will be, since these cholangiocytes are damaged, whenever they get damaged, they'll release this enzyme called GGT, gamma glutamyl transaminase or transpeptidase. So if we, and this will we can come to know while doing LFT, blood test, liver function test ali, if there is elevated GGT, that indicates that there is something wrong with cholangiocytes. Okay, so formation of multiple strictures, what will this cause? Multiple strictures will lead to increasing the chance of infection, so increased risk of cholangitis. And then stricture ಆಗಿದೆ, ಸೊ ಇವಾಗ ಯೂಶ್ವಲಿ ಸಣ್ಣ ಸ್ಟೋನ್ಸ್ ಎಲ್ಲ ಪಾಸ್ ಆಗ್ತಿತ್ತು, ಇಷ್ಟು ದಪ್ಪ ಇದೆ. ಐ ಮೀನ್ ಇಫ್ ದ bile duct is this large, some gallstones would have passed through this, but now since there is stricture, gallstones will get accumulated, hence this leading to increased CBD stones. Then acute pancreatitis, whatever the inflammatory products are there, that can lead to accumulation, or that can lead to obstructions of pancreatic duct as well. So pancreatic duct obstruction ಆಯ್ತಂದ್ರೆ, ಇವಾಗ ಇಲ್ಲೆಲ್ಲ obstruction ಆಯ್ತಂತ ಅಂದ್ಕೊಳ್ಳಿ, pancreatitis ಇಂದ ಏನು ಬರ್ತಾಯಿತ್ತು, digestive enzymes, that will also get obstructed, that will lead to damage to the surrounding tissues of pancreas, leading to acute pancreatitis. And then at last it can lead to carcinoma of the bile duct, that is cholangiocarcinoma. Okay, so these are all the complications, or the patient can be asymptomatic or might present in complications like cholangitis, CBD stones, acute pancreatitis, or cholangiocarcinoma. Okay, so how will we diagnose? Basically, investigation of choice is MRCP, whereas gold standard is ERCP, because while diagnosing only, if we diagnose anything, we can treat it then and there. Hence ERCP is gold standard. Characteristic appearance ಹೇಗಿರುತ್ತೆ ERCP ಮಾಡುವಾಗ, how can we diagnose this primary sclerosing cholangitis ಅಂದರೆ, there will be beaded appearance. ಬೇಸಿಕಲಿ beaded ಯಾಕಿರುತ್ತೆ, ಇವಾಗ ಹಿಂಗಿದೆ, ಇಲ್ಲೊಂದು ಕಡೆ ಸ್ಟ್ರಿಕ್ಚರ್ ಆಯಿತು, ಮತ್ತು ಕಂಟಿನ್ಯೂ ಆಗುತ್ತೆ, again there will be a stricture, again it will continue. So whatever these, it is appearing like a string with beads, ರುದ್ರಾಕ್ಷಿ ಅಥವಾ ಏನೋ ಒಂದು ಮಣಿಸರ ಇರುತ್ತಲ್ಲ, ಆ ಥರ ಕಾಣಿಸುತ್ತೆ. This is a stricture, this is normal bile duct, this is a stricture, this is normal bile duct, stricture, normal bile duct. Because of that, whenever we are doing ERCP, it will be beaded appearance, and there will be pseudo-diverticular appearance. Okay, so what is the treatment now? Basically, this is an autoimmune disease. We can treat with immunomodulator or immunosuppressant drugs or high dose UDCA. This is medical management of gallstones ಹೇಳಿದ್ನಲ್ಲ, ursodeoxycholic acid. ಏನು ಬೇಸಿಕಲಿ ಏನು ಮಾಡುತ್ತಿದ್ದು, HMG CoA reductase ಎಂಜೈಮ್ನ ಇನಿಬಿಟ್ ಮಾಡುತ್ತೆ, ಬೇಸಿಕಲಿ ಫಾರ್ಮೇಷನ್ ಆಫ್ ಗಾಲ್ ಸ್ಟೋನ್ಸ್ನ ಕಮ್ಮಿ ಮಾಡುತ್ತಷ್ಟೆ. ಆಯಿತಾ? ವೆರಸ್ ಡೆಫಿನೇಟಿವ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಆರ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಆಫ್ ಚಾಯ್ಸ್ ಈಸ್ ಲಿವರ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟೇಷನ್. Okay, after this comes to end of primary sclerosing cholangitis. After this, one more pathology we need to discuss is cholangiocarcinoma, that is cancer of bile duct. So cholangiocarcinoma dalli enagutte, just like I said, this is right hepatic duct, left hepatic duct, illinda cystic duct barutte, both will form common bile duct, that will lead join the pancreatic duct, and it will open the ampulla of Vater. Okay na? So basically cholangiocarcinomaದಲ್ಲಿ there will be arisal of mass anywhere from the bile duct, ಇಲ್ಲಿಂದ ಬರ್ಬೋದು, anywhere. So there will be a formation of mass from the bile duct. This itself is cholangiocarcinoma. ಆಯಿತಾ? ಸೊ ಇದಕ್ಕೆ ಏನೇನೆಲ್ಲ ರಿಸ್ಕ್ ಫ್ಯಾಕ್ಟರ್ಸು, ವಾಟ್ ಎವರ್ ವಿ ಹ್ಯಾವ್ ಸ್ಟಡಿಡ್ ಟಿಲ್ ನಾವು. ಫಸ್ಟ್ ಒನ್, ಕೊಲೆಡೋಕಲ್ ಸಿಸ್ಟ್, ಬೇಸಿಕಲಿ ಅಬ್ನಾರ್ಮಲ್ ಡೈಲೇಟೇಷನ್ ಆಫ್ ಬೈಲ್ ಡಕ್ಟ್. ಸೊ ಅಬ್ನಾರ್ಮಲ್ ಡೈಲೇಟೇಷನ್ ಆಗುತ್ತೆ, ಆಮೇಲೆ ಇಲ್ಲೇನು ಮಾಡುತ್ತೆ, ದಿಸ್ ವಿಲ್ ಟ್ರೈ ಟು ಫಿಲ್ ಅಪ್ ದ ವಾಟ್ ಎವರ್ ದ ಕೊಲೆಂಜಿಯೋಸೈಟ್ಸ್ ಆರ್ ದೇರ್, ದೇ ವಿಲ್ ಟ್ರೈ ಟು ಫಿಲ್ ಅಪ್ ದಿಸ್ ಡೈಲೇಟೇಷನ್, and that will lead to formation of a mass, that leading to cholangiocarcinoma. After that, choledocholithiasis. Choledocholithiasis ಅಂದರೆ bile duct stones. So bile duct stones, whatever is there, that can lead to obstruction and thereby causing inflammation and thereby causing mass, that is cholangiocarcinoma. After that, primary sclerosing cholangitis. We have discussed it just now. Primary sclerosing cholangitis andre there will be multiple strictures. So these multiple strictures, whatever are there, they can lead to formation of mass because of infection. Again, cholangitis ಮಾಡಬಹುದು ಅದು, cholangitis ಆಗಬಹುದು ಅಥವಾ ಕೊಲಿಡೋಕೊಲಿಥಿಯಾಸಿಸ್ ಕಾಸ್ ಮಾಡಬಹುದು, thereby leading to cholangiocarcinoma. Other than that, ulcerative colitis. How can ulcerative colitis cause cholangiocarcinoma? Just like I said, ulcerative colitis is associated with primary sclerosing cholangitis. ಯಾರಿಗೆ ಪ್ರೈಮರಿ ಸ್ಕ್ಲಿರೋಸಿಂಗ್ ಕೊಲೈಜೈಟಿಸ್ ಇರುತ್ತೆ ಅವ್ರಿಗೆ 60-80% ಅಲ್ಸರೇಟಿವ್ ಕೊಲೈಟಿಸ್ ಆಗುತ್ತೆ. So ulcerative colitis again can lead to, since primary sclerosing cholangitis can lead to cholangiocarcinoma, ulcerative colitis can also lead to cholangiocarcinoma. Other than that, cirrhosis, liver cirrhosis, same. Then all these infections, this can lead to cirrhosis and that can lead to cholangiocarcinoma. Basically metastasis ತರ ಅನ್ಕೊಳ್ಳಿ. Other than that, all these drugs and all, diabetes, obesity, OCPs, smoking, these all can cause cholangiocarcinoma. Most common site is hilum and hence the name hilar cholangiocarcinoma. Okay na? This is also called as clad skin tumor. Okay, istondenu bekilla. So what are the similarities between cholangiocarcinoma and gallbladder carcinoma? This is important. Cholangiocarcinoma is the carcinoma of bile duct, whereas gallbladder carcinoma is carcinoma of the gallbladder. So both are adenocarcinoma. Adenocarcinoma is the carcinoma that is arising from a glandular tissue. Adeno stands for gland. Okay, both are adenocarcinoma. After that, CEA, that is carcinomatous embryonic antigen. Okay, so that is non-specific marker, whereas specific marker is CA19-9. ಆಯಿತಾ? So after this, chemotherapy regimen ಎರಡಕ್ಕೂ gemcitabine plus cisplatin. Okay. Other than that, histological types for both are diffuse or infiltrative or sclerosing, nodular or mass forming, and papillary. Okay. So what are the clinical features which is common for both? Most common presentation is painless progressive jaundice followed by weight loss. Okay na? Like there will be painless. Initially there will be no pain, and progressive jaundice. Initially ಸ್ವಲ್ಪ yellow ಇರ್ತಾರೆ, only suppose only eyes will be yellow. After that eyes and entire skin will become yellow. After that there will be losing of weight. ಆಯಿತಾ? ಈ ಥರ ಪ್ರೆಸೆಂಟೇಷನ್ ಇರುತ್ತೆ. And then there will be symptoms of painless progressive jaundice like anorexia, fatigue, pruritus, and passage of clay colored stools. These are all the symptoms in case of both gallbladder carcinoma and cholangiocarcinoma. Okay. After this, we need to know about a law called Courvoisier's law. What does it suggest? In case of an obstructive jaundice due to stone disease, gallbladder will not be palpable, because if the stone, ಇವ್ರೇನು ಹೇಳ್ತಾನೆ ಗೊತ್ತಾ, if there is a stone, gallstone, which is causing obstructive jaundice, basically now this will be cystic duct ಅಂತ ಅಂದ್ಕೊಳ್ಳಿ, right hepatic duct and left hepatic duct, common hepatic. So gallbladder ಹಿಂಗಿದ್ರೆ, if this stone has obstructed and is now causing obstructive jaundice, by the time it will be so much chronic that all this gallbladder would have got fibrosed anta. So if a stone is leading for obstructive jaundice, then it will be chronic. ತುಂಬ ಟೈಮ್ ಆಗಿದೆ ಆಲ್ರೆಡಿ ಸ್ಟೋನ್ ಇಲ್ಲಿಗೆ ಬಂದು ಅಬ್ಸ್ಟ್ರಕ್ಟ್ ಮಾಡಿ ಜಾಂಡಿಸ್ ಕಾಸ್ ಮಾಡೋದಕ್ಕೆ. ಅಷ್ಟರೊಳಗೆ ಏನಾಗಿರುತ್ತೆ, ಗಾಲ್ ಬ್ಲಾಡರ್ would have fibrosed and hence it will not be palpable. So in case of obstructive jaundice due to gallstone, there will be no palpable gallbladder because it is chronic and gallbladder has got fibrosed. This law is called as Courvoisier's law. If the gallbladder is palpable and there is obstructive jaundice, then it is not due to gallstone. ಇದನ್ನು ಹಿಂಗೋ ಅರ್ಥ ಮಾಡ್ಕೋಬೋದು. ಸೊ ಬೇಸಿಕಲಿ ಇಫ್ ದ gallbladder is palpable and the patient is having obstructive jaundice, we should not look for gallstones. There can be some other cause. ಅದಕ್ಕೆ ಹುಡುಕಿ ಅಂತ ಅಷ್ಟೇ. ಆಯಿತಾ? ದೆನ್ ಎಕ್ಸೆಪ್ಷನ್ಸ್, if there is double impaction of stone, that is one in the cystic duct and one in common bile duct, then the Courvoisier's law is false. ಆಯಿತಾ? ದೆನ್ ಮ್ಯೂಕೋಸೀಲ್ ಇದ್ದರೆ ದೆನ್ Courvoisier's law is false. ಓಕೆ. ಅದರ್ ದನ್ ದಿಸ್, ಸ್ಟೋನ್ ಇಂಪ್ಯಾಕ್ಟೆಡ್ ಅಟ್ ಆಂಪಿಲ್ ಆಫ್ ವೇಟರಲ್ಲಿದ್ದರೂ ದಿಸ್ ಲಾ ಡಸಂಟ್ ಹೋಲ್ಡ್ಸ್ ಗುಡ್. ಆಯಿತಾ? ಸೊ ಬೇಸಿಕಲಿ ಇಫ್ ಯು ಹ್ಯಾವ್ ರೂಲ್ಡ್ ಔಟ್ ದೀಸ್ 3 ಪಾಸಿಬಿಲಿಟೀಸ್, 2 ಸ್ಟೋನ್ ಇಲ್ಲ, ಮ್ಯೂಕೋಸೀಲ್ ಇಲ್ಲ, stone is not at the ampulla of Vater, then you can use Courvoisier's law, otherwise it will not hold good. Okay, after this, how do we diagnose cholangiocarcinoma? We'll do MRI and MRCP, which is investigation of choice. Iveredu possibility illa andre we can go for contrast enhanced CT scan. So why we should avoid contrast enhanced CT scan andre, because there is increased risk of hepatorenal syndrome. Okay, so how do we manage this cholangiocarcinoma? If there is hilar cholangiocarcinoma, we'll go for common bile duct resection and routine caudate lobectomy and lymphadenectomy. Okay, if it is distal cholangiocarcinoma, then we'll go for pylorus preserving Whipple's procedure. Okay, for advanced and metastatic changes, we'll go for palliation, that is chemotherapy. ಎಷ್ಟು ದಿನ ಇರ್ತಾರೆ ಅಷ್ಟು ದಿನ ನೋಡ್ಕೊಳ್ಳೋದಷ್ಟೇ. ಸೊ ಇಫ್ ಯು ಹ್ಯಾವ್ ಅಂಡರ್ಸ್ಟುಡ್ ದಿಸ್, ಐ ಮೀನ್ okay, I'll explain it once again. ಸೊ ಏನು ಹೈಲಾರ್ ಕೊಲಾಂಜಿಯೋಕಾರ್ಸಿನೋಮಾ ಅಂತ ಹೇಳ್ತಾ ಇದ್ದೀನಿ, ಏನದು ಹಂಗಂದರೆ ಹೈಲಮ್ ಬೇಸಿಕಲಿ ಸಿಸ್ಟಿಕ್ ಡಕ್ಟು ಎಲ್ಲಿಗೆ ಕಾಮನ್ ಹೆಪಾಟಿಕ್ ಡಕ್ಟ್ನ ಜಾಯ್ನ್ ಆಗುತ್ತಲ್ಲ, ದ್ಯಾಟ್ ರೀಜನ್ ಈಸ್ ಕಾಲ್ಡ್ as ಹೈಲಮ್. ಸೊ ಯೂಶಲಿ ಕೊಲಾಂಜಿಯೋಕಾರ್ಸಿನೋಮಾ ಈಸ್ ಮೋಸ್ಟ್ ಕಾಮನ್ ಇನ್ ದಿಸ್ ರೀಜನ್, ಹೈಲಾರ್ ರೀಜನ್. ಇಫ್ it is hilar cholangiocarcinoma, then what we'll do, we'll go for common bile duct resection. Basically we'll remove this plus caudate lobe, because caudate lobe usually ಹೆಂಗಿರುತ್ತೆ, ಇವಾಗ ಇಲ್ಲಿ ಲಿವರ್ ಇರುತ್ತೆ, this will be the gallbladder and this will be the caudate lobe. Caudate lobe ectomy, because this will be spreading like this. So caudate lobectomy plus common bile duct resection plus whatever the lymph nodes are there around this, will remove this. That is lymphadenectomy. So basically hilar cholangiocarcinoma, illinda carcinoma arise ಆಗ್ತಾ ಇದ್ರೆ we'll do this. If it is distal to this, distal ಅಂದರೆ ಎಲ್ಲಿಗೆ ಹೋಗುತ್ತೆ, obviously it will go along with the pancreas into the intestine. So because of that intestine, stomach ಇಂದು ಲಾಸ್ಟ್ ಪಾರ್ಟ್ ಪೈಲೋರಸ್, along with that, ಬಟ್ ಪೈಲೋರಸ್ನ ಪ್ರಿಸರ್ವ್ ಮಾಡ್ತೀವಿ, ರಿಮೈನಿಂಗ್ ಸ್ಟ್ರಕ್ಚರ್ಸ್ ವಿಲ್ ಗೋ ಫಾರ್ ವಿಪ್ಪಲ್ಸ್ ಪ್ರೊಸೀಜರ್. ರೋ ಎನ್ ವೈ ಗ್ಯಾಸ್ಟ್ರೋಜೆಜಿನಾಸ್ಟಮಿ ಅದೆಲ್ಲ ಓದಿದ್ವಲ್ಲ, ಹೆಪಾಟಿಕೋ ಗ್ಯಾಸ್ಟ್ರೋಜೆಜಿನಾಸ್ಟಮಿ, ದ್ಯಾಟ್ ಪ್ರೊಸೀಜರ್. ಓಕೆ, ಇನ್ನೂ ಅಡ್ವಾನ್ಸ್ಡ್ ಆಗಿದೆ ಅಂದರೆ ವಿ ಕ್ಯಾನ್ ಡೂ ಎನಿಥಿಂಗ್ ಅದರ್ ದ್ಯಾನ್ ಪ್ಯಾಲಿಯೇಟಿವ್ ಥೆರಪಿ. ಸೊ ದಿಸ್ ಕಮ್ಸ್ ಟು ಎಂಡ್ ಆಫ್ bile duct pathologies. In bile duct part 2 we have discussed two main pathologies, that is primary sclerosing cholangitis and cholangiocarcinoma. So overall, yeah, ಇದೊಂದು ಹೇಳಬೇಕಿತ್ತು, ಸಿನ್ಸ್ ಯುವರ್ ಕರಿಕ್ಯುಲಮ್ ಸ್ಪೆಸಿಫಿಕಲಿ ಮೆನ್ಷನ್ಸ್ ಅಬ್ಸ್ಟ್ರಕ್ಟಿವ್ ಜಾಂಡಿಸ್, ವಾಟ್ ಎವರ್ ದ ಪ್ಯಾಥಾಲಜೀಸ್ ವಿ ಹ್ಯಾವ್ ಡಿಸ್ಕಸ್ಡ್ ಅದೇ ಅಬ್ಸ್ಟ್ರಕ್ಟಿವ್ ಜಾಂಡಿಸಲ್ಲಿ ಬರೋದು. ಬೇಸಿಕಲಿ ಯು ವಿಲ್ ಹ್ಯಾವ್ ಟು ಅರೇಂಜ್ ಇಟ್ ಲೈಕ್ ಕಾಸಸ್ ಆಫ್ ಅಬ್ಸ್ಟ್ರಕ್ಟಿವ್ ಜಾಂಡಿಸ್ ಥರ. ಓಕೆನಾ? ಸೊ ದೀಸ್ ಆರ್ ದ ಕಾಸಸ್ ಆಫ್ ಅಬ್ಸ್ಟ್ರಕ್ಟಿವ್ ಜಾಂಡಿಸ್ ಆರ್ ಕ್ಲಾಸಿಫಿಕೇಶನ್. ಸೊ ಕಂಜನೈಟಲಿ ಇದರಲ್ಲಿ ಬಂದರೆ ವಿ ಹ್ಯಾವ್ ಡಿಸ್ಕಸ್ಡ್ ಕೊಲೆಡೋಕಲ್ ಸಿಸ್ಟ್, ಆಯಿತಾ? ಸೊ ದ್ಯಾಟ್ ಈಸ್ ಅ ಕಂಜನೈಟಲ್ ಕಾಸ್. Okay, inflammatory cholangitis we have discussed, and sclerosing cholangitis, this is primary sclerosing cholangitis, and other one is cholangitis, just inflammation which can be because of obstruction or infection. And next, obstructive causally we have discussed ಕಾಮನ್ ಬೈಲ್ ಡಕ್ಟ್ ಸ್ಟೋನ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಆಗ್ಬೋದು, ಅಥವಾ ಸ್ಟ್ರಿಕ್ಚರ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಮಾಡ್ಬೋದು, ಅಥವಾ ವರ್ಮ್ಸ್ ಲೈಕ್ ಆಸ್ಕ್ಯಾರಿಸ್ ಇವು ಹೋಗಿ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಮಾಡ್ಬೋದು. ನೆಕ್ಸ್ಟ್ ನಿಯೋಪ್ಲಾಸ್ಟಿಕ್ ಲೈಕ್ ಕೊಲಾಂಜಿಯೋಕಾರ್ಸಿನೋಮಾ ಈಗಿನ ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ವಿ. ಹೈಲಾರ್ ಕೊಲಾಂಜಿಯೋಕಾರ್ಸಿನೋಮಾ ಇಸ್ ನಥಿಂಗ್ ಬಟ್ ಕ್ಲಾಟ್ ಸ್ಕಿನ್ ಟ್ಯೂಮರ್, ಸೊ ದ್ಯಾಟ್ ಕ್ಯಾನ್ ಬಿ ಅ cause, neoplastic cause for obstructive jaundice. Carcinoma of head of the pancreas or periampullary carcinoma, these can also be a cause for neoplastic cause for obstructive jaundice. Other than this, Meniere's syndrome ಇದನ್ನು ನಾವು ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ವಿ. ಲೈಕ್ if there is a bile duct which is going and if there is a stone which is going and obstructing the extrahepatic bile duct, that will lead to, or if there is external cause which is compressing the bile duct. ಇವಾಗ ಎಕ್ಸ್ಟರ್ನಲ್ ಕಾಸ್ ಏನಾಗಿರ್ಬೋದು, ಇಫ್ ಸೊ ಲೈಕ್ ದಿಸ್, ಇವಾಗ ಇಂಟೆಸ್ಟೈನ್ ಇಲ್ಲಿ ಏನೋ ಒಂದು if this externally it is compressing the bile duct. Basically any external source that is compressing the common bile duct, that is called as Meniere's syndrome. So these are all causes for obstructive jaundice which we have discussed till now. Just we need to think of it and put it in a separate table ಅಷ್ಟೇ. So what are the causes ಅಂತ ಕೇಳಿದರೆ ಇದೆಲ್ಲದನ್ನು ಬರೆದು we can just go on explaining about these topics. So this comes to the end of bile duct. So till now we have covered liver, gallbladder and bile duct. Next we'll be starting with pancreas. Okay, ಏನಾದ್ರು ಡೌಟ್ಸ್ ಇದೆಯಾ? Okay, ಏನು ಡೌಟ್ಸ್ ಇಲ್ಲ ಅಂದರೆ we can end the session then. Since we have started late, we are ending it fast. Okay, and anyhow bile duct ಅಂತ separate topic ಇಲ್ಲ ನಿಮಗೆ. I have explained all this in order to clear the topics for obstructive jaundice ಅಷ್ಟೇ. Obstructive jaundice is mentioned in your curriculum. So in order to understand what are the causes for obstructive jaundice, you need to understand whatever the pathologies of bile duct also. Because of that I have explained it. Okay la? If there are no doubts we can end it.
Okay, thank you.
Okay, thank you everyone.